Go to the board.
Thank you so much, sir. So we have our next speaker, Dr. Namitha Narayanan, MD, Internal Medicine, DCH, Associate Professor, Department of General Medicine, Government Stanley Medical College and Hospital, Chennai. She is an invited speaker at Epicon 2019, 2020, 2022, Tapicon 2021 and Meher FTP. She is also a faculty, MU Government Stanley Medical College, Chennai. She is a member expert committee on poisoning management, Government of Tamil Nadu. She will be speaking on the topic continuous glucose monitoring and current concepts.
A very good morning to one and all present here. At the outset, let me thank the organizers, especially Dr. Arulraj sir and Dr. Parandaman sir for having given me this opportunity. I bring you all warm greetings from Stanley Medical College. Moving on to the topic on continuous glucose monitoring systems, current concepts, I think Dr. Appanraj has made my job easy. We are in a tech-savvy world, and diabetes technology is an all-encompassing terminology, which implies hardware, newer devices, and intuitive software, helping people with diabetes to manage their conditions more effectively. So it basically consists of two categories. One is administration of insulin through a syringe, pen, or pump, and the assessment of blood glucose through blood glucose monitoring. And another one is CGM, continuous glucose monitoring. And now we have hybrid devices which monitor both the blood glucose and also which can be conjoined with the insulin pumps. So assessment of glycemic control in diabetes, we have HbA1c measurement, blood glucose monitoring, and continuous glucose monitoring, HbA1c being the gold standard. How does CGM help here? It plays an important role in the management of several patients with type 1 diabetes. And in some patients with type 2 diabetes, the benefits being better diabetes control, decreased incidence of hypoglycemia, and enhanced self-efficiency. So what are the devices available? It measures interstitial glucose, correlates well with the plasma glucose, and as we all know, there is a time lag. And the devices available are the real-time CGM systems, which measure and store glucose levels continuously and without prompting. The intermittently scanned devices, which measure glucose level continuously but require scanning for the storage of glucose values. And professional CGM devices, which we give to the patients for a period of 14 days. And what is the type of device which the patient select depends on the indications, the specific needs of the patient, the skill levels, the technical knowledge of the patient, and the availability of the respective devices, and of course the cost. And we need to train both the patient and the caretakers for the use of the CGM machine. What are the components? We have a sensor, the transmitter, the receiver, and the receiver batteries. The receiver just displays not only the current glucose reading, but also the past readings and also the glucose trends, which are shown as arrows to show if glucose is stable, rising or falling, and how quickly it is changing. This is how a sensor and a transmitter looks. And the CGM's readings can be put on a mobile app, so user-friendly. It also gives you alerts of low glucose, high glucose, 60-minute predictive values, and also customizable values. So there is a difference between the plasma glucose and the sensor. As we said, because it tests the interstitial glucose, we have a time lag of almost 5 minutes, which is depicted here. The green arrow shows the plasma glucose, and the red one is the sensor. And also, what are the standardized CGM metrics for clinical care? One is the number of days that the CGM device is worn, the percentage of time that the CGM device is worn, the mean glucose levels, and of course the glucose management indicator, which is the estimated HbA1c, the glycemic variability or percentage of coefficient variation, which should be less than 36%, time above range, and time and percentage of readings more than 250 milligram per deciliter, which indicates level 2 hyperglycemia, time above range, that is 181 to 250, indicating level 1. Time in range is very important, that is a 70 to 180 milligram per deciliter, which is in range of glucose levels and which we desire patients to have at least 70% of the time. Time below range, we have again level 1 and level 2 hypoglycemia, level 1 being 54 to 69 and level 2 being less than 54 milligram per deciliter. This is, I'm sorry for this crowded slide. The ambulatory profile, which I'll show you again in the next slide, it is red in the median. You have a 50th percentile, and then a 75th percentile, and a 25th percentile. So this is how it looks, a daily log of a patient from 19th April to 2nd May. It does show a hypoglycemia, as seen in the red arrow there, and also the glucose readings. This is the next 1 week. This also shows the average glucose value, say it is 155 on day 1, 149 on second day, and so it goes. And this is the profile which shows that the mean glucose. The center line shows the 50th percentile, which is about 154 is the desired value. And then we have all those dots which are seen there are the glucose values there. And the red dots show us the hypoglycemia. So what are the challenges? One is contact dermatitis, and another is the cost. So assessment of glucose by continuous glucose monitoring. We know blood glucose monitoring is established as an important intervention in the management of diabetes, but the parameters like time and range and glucose management indicator, which is a standard method for glucose monitoring in type 1 diabetes, standardized reports with visual cues. This enables the patients per se and the providers to interpret the data effectively and initiate approaches and appropriate treatment decisions. So glycemic goals in CGM for diabetes management, as we said, the time and range, it correlates closely with the risk of microvascular complications and with HbA1c. Studies have shown that the goal of 70% of time and range aligns closely to HbA1c of 7%, and time and range below 70 milligram, that should be only 4% in a 24-hour time, and less than 54, desirable will be less than 1% in a 24-hour interval. So, continuing with the glycemic goals, A1C is the primary measure to guide the management of diabetes and a risk marker for the development of complications. And the CGM metrics are dictated by patient-specific goals, which in turn shall determine the frequency, timing, and consideration of the CGM use. Now, what are the indications? It is better if it is started early, on young patients especially, because it allows improved tracking on blood sugar levels, suitable adjustments of insulin dosing, appropriate lifestyle modifications, and eliminates the burden of frequent blood glucose monitoring. And what are the ADA 2022 recommendations for CGM and diabetes? Real-time CGM or intermittently scanned continuous glucose monitoring can be offered to adult diabetics who are on multiple daily injections or on continuous subcutaneous insulin infusion, and also to adult diabetics on basal insulin who are capable of safely using these devices, and for young diabetics with either type 1 or type 2 on multiple daily injections and continuous insulin infusion, and who are capable of handling these devices. Additional recommendations being it can be used almost daily, and in case of intermittent scan, it should be scanned at least 8 hourly. And in type 1 diabetes, the frequency of sensor utilization and the frequency of swiping in case of intermittent devices correlates with improved outcome and better lowering of HbA1c. Periodic usage is recommended where the devices are not available. So what are the benefits of using a real-time CGM? Significant lowering of HbA1c and significant lowering of episodes of hypoglycemia. This has been reported in certain studies. And in type 2 diabetes mellitus, we have substantial improvement in HbA1c, but there is no much improvement in hypoglycemia. What about intermittent scan CGM machines? Data from RCTs are very limited and not very encouraging. Some studies have shown reduction in HbA1cs, and others have shown reduction in the incidence of hypoglycemia. But both in type 1 and type 2 diabetics, the reduction of acute diabetic complications and all-cause hospitalizations have been seen to be reduced. So RT-CGM versus intermittent CGM, there have been 3 or 4 studies. 2 of the studies have shown that the time spent in hypoglycemia was lower in RT-CGM users when compared to intermittently scanned CGM users. And the 3rd study demonstrated an improvement in time and range in RT-CGM users. So professional continuous glucose monitoring is used to evaluate patients in situations where these machines are not available, and patients prefer to go with a blinded analysis in diabetic management, and also to use to identify patterns of hypo or hyperglycemia. So in pregnancy, I think Apanraj sir has already told, so I'm skipping the slide. Moving on to hypoglycemia in type 1 diabetics, the primary endpoint of reduction in hypoglycemia reported significant reduction in time spent between 54 and 70 milligram per deciliter, whereas in type 2 diabetics, there was no much impact on hypoglycemic events, but there was an improvement in HbA1c levels. What about CGM and advanced CKD? We all know that HbA1c accuracy decreases as GFR decreases. CKD patients experience large glycemic excursions, and therefore HbA1c with SMBG is inadequate for assessing glycemic variability. And limitations of current glucose monitoring methods in CKD: inter-day assessment, we have limited utility because we know erythropoietin-stimulating agents can falsely lower HbA1c, and metabolic acidosis and uremia can falsely increase HbA1c. And intra-day assessment, inability to detect SMBGs, inability to detect trends of the rapidly changing or fluctuating glucose levels. So it is useful in patients on HD and PD. HD patients, composition of dialysate and membrane, it causes a glycemic variability. We all know that during HD, the patient goes for a hypo, and post-HD, they go for a rebound hyperglycemia. All this can be prevented using a CGM, and PD patients, CGM helps in determining the timing, route, and dose of insulin administration. The limitations of CGM and dialysis again being potential sensor interferences from endogenous and exogenous substances, and accuracy of CGM decreases due to the glycemic disarray there. What about in-hospital? Traditional glucose monitoring measures glucose only at a given point of time, whereby the asymptomatic hypoglycemia, especially at night, can be missed. CGM continuously measures and documents the trend and also directs of changes over time. So what are the ADA recommendations? Patients already using CGM should be allowed to use them in hospital under supervision. And American Association of Clinical Endocrinologists recommend that CGM can be used in hospital in patients who are cognitively intact and where we have a diabetic team. And in hospital, if the sugar ranges are above 40 to 50, beyond these levels, we should not be relied upon. And sensor glucose value should be confirmed again with the point of care glucose testing. But it has been useful in COVID pandemic times. And CGM devices are not approved for use when we have exposure to radiation like X-ray, CT scan, diathermy, etc. Patients should be instructed to remove these devices. And it is not useful again in critical care where we have patients in shock and on inotrope support. To conclude, continuous glucose monitoring has facilitated control and management of diabetes. CGM parameters, which include time and range, glucose management indicator, and time below range and above range. These are the new CGM metrics. And the criteria enable better reduction of HbA1c levels along with lower incidence of hypoglycemic attacks, especially in type 1 diabetics. And it facilitates precise round-the-clock diabetic care useful in pregnancy and CKD. And advancements in diabetic technology enables us to inch closer and closer to the elusive state of physiological glucose homeostasis. I thank again the organizers, especially Parandaman sir and Arulraj sir, and also all my teachers past and present who have helped me with this presentation. Thank you one and all.
Thank you, doctor. You have made it very clear about the CGMS. Of course, after the insulin invention in 100 years back, the next dream of Dr. Priscilla White was measuring blood sugar with a drop of blood. And we have progressed much further up to CGMS. You have made it very clear from A to Z. It was crystal clear and very simple. Thank you, doctor.
Thank you.
Wonderful presentation, madam. And see, let's see. No, the normal HbA1c in non-pregnant is different and pregnant is different. Pregnant is anything more than 5.3 is abnormal, everyone know. How to maintain the normalcy? The problem here is if HbA1c is more than 8%, the risk of malformation increases by 5%. If it is more than 10% of HbA1c, the malformation increases by 25%. The good point here is if you reduce a 1% HbA1c reduction, it decreases the malfunction by 50%. See, just 1% HbA1c reduction decreases malformation by 50%. That is why the role of CGM is there. That is why the first topic was taken as a CGM to prevent the future. Our Diane, the field of our father of diabetology, used to tell that prevent diabetes, focus on future, focus on fetus for future prevention. So it's wonderfully dealt, madam. You have covered everything. Both of you and all three of you covered the entire aspect of this GDM management, how to tight control blood sugar to prevent metabolic as well as health-related complications. Thank you very much. With this, we close this session.
I'd like to thank Professor Dr. A. Bhavtar Nimam and Professor P. Parandaman sir for chairing the session.